Ուրախ եմ հայտնելու, որ մենք հյուրընկալում ենք կանադայի սրտային վիրաբույժ շատ սիրելի հայտնի Մարալ Ուզունյանին։ Ասեմ, որ դոկտոր Ուզունյանը մասնավոր հայցով է Հայաստանում եւ շատ շնորհակալ ենք, որ ժամանակ գտավ եւ մեզ հյուր եկավ։ Դոկտոր Ուզունյան, խնդրեմ։
Շնորհակալություն Դոկտոր Հեբոյան եւ խումբին, որ ինձ այսօր հրավիրեք հոս, շատ ուրախ եմ հոսը լալու, անգլերենով պիտի խոսիմ, բայց եթե կրնամ թանթաղիլ, եթե հստակ չէ, կրնամ նորեն ասել, հաճիկ interrupt as we go. I'm a cardiac surgeon and aortic surgeon in Toronto. I trained mostly in Canada. I did my medical school at McGill, my cardiac surgery training at Dalhousie, my PhD in Toronto. And then I spent 1 year in Houston to do specialized training in aortic surgery with Dr. Caselli. And I've been on faculty in Toronto at the University of Toronto, Toronto General Hospital for 8 years there. I'm the fellowship director there and I run the aortic surgery program, and I'm very happy to be here today. I'm going to speak on type A dissection, and particularly how we address the arch in the setting of acute type A dissection. This is quite a controversial area, quite a controversial area with a lot of progress in the field. We'll talk through some cases and describe some innovations in the field with new technology and how we do address patients with this problem. So, discussing. Let's see. Uh-oh. That's not a good sign. I don't know. It was working. Oh no. Should we restart? Yeah. Let's see. Okay, Yerav. Perfect. Discussing. So, as everyone knows, type A dissection is a very critical, urgent problem that is almost completely fatal without immediate operation. And I know Dr. Heboyan and his team have been fighting to have this surgery paid for by the government here. And it's a problem in Armenia that patients with acute type A dissection, if you need urgent care and should be offered immediate surgery that's life-saving. So we'll talk here about 3 different approaches to the arch in the setting of acute type A dissection. 3 different techniques, 3 different cases, and I'll talk a little bit about in our program in Toronto how we approach these cases. So the first case is a 55-year-old healthy gentleman who developed chest pain and then left leg numbness. It was the numbness in his leg that prompted him to seek medical attention. When he came to the emergency room, his left leg was ischemic, cold, no pulse, but he could still move it. He had some right arm weakness and numbness briefly, but that resolved. And he was quite stable hemodynamically. Now, my movies are not playing here, so I'm going to play them for you here so you can see the CT scan. It's a little bit hard to see, but essentially he has no flow to his left carotid. He has a big type A dissection, a large root aneurysm, and then no flow down his legs. So let me just, Okay, so you see here, left carotid is gone, his left common femoral artery is gone, his arch is dissected, and his root is quite large. So this is his echo. The echo's not playing, but it's a typical echo that we see in acute type A dissection of some aortic insufficiency and a large root aneurysm. So this gentleman, okay, so just to remind us that acute type A dissection has still today very high operative mortality, even though outcomes have improved over time. The surgical mortality for acute type A dissection is still very high. 20 to 25% of patients, even if they come to surgery, will die in the next 30 days or soon after surgery. And even if you survive surgery, your long-term outcome is compromised. Only 50% of people will be alive after 10 years. And the 10-year reintervention rate on the arch and distal aorta is quite high, and those are very morbid, difficult operations. So the one other major point is if you have acute type A dissection with malperfusion, your mortality is much, much higher than if you have no malperfusion. And that's a very important point. If we only do a standard hemiarch repair, there's flow in the distal false lumen a lot of the time, majority of the time, 50 to 70% of the time. And this is the standard operation, the minimum basic operation for acute type A dissection. We have to resect the tear, replace the ascending aorta. Usually we can simply resuspend the valve and save the valve by doing a resuspension of the aortic valve and resect the ascending aorta and do a hemiarch replacement. Okay, this is the minimum standard operation for acute type A dissection. But this is not an adequate operation for patients with a large arch aneurysm or those with a tear in the arch, and also those with distal malperfusion. If we only do this operation in malperfusion, there's a very high mortality. So we wrote these Canadian guidelines now 5 years ago, and we suggested that for patients who have these conditions, an aneurysmal arch, a tear in the arch, distal malperfusion, young patients or those with connective tissue disorders, and those with aneurysms in the descending thoracic aorta, they should undergo a more extensive arch operation at the time of acute type A dissection. And some of the reason is the tear, which we think of as usually being in the ascending aorta, is not always in the ascending aorta. Often it can be in the arch, in the descending aorta, or we can't always see the tear. So it's not always enough to only replace the ascending aorta. And we know from large registries, this is the German Gerade registry, we know that malperfusion is one of the most important factors for death after type A dissection. If you have no malperfusion, 12% death. If you have 3 organ systems malperfused, 40% death. So with each organ system that's malperfused, the death rate is much, much higher. So we have to do something more. One of the issues that we are seeing more of now is this concept called DANE, distal anastomotic new entry tear. When we do our anastomosis at the distal ascending aorta at the arch, the needle holes can make a new tear that acts like a new tear for the type A dissection. And that's what it looks like in the operating room. And if we leave the hospital with this problem, then we have more problems down the road, more aortic growth, more patent false lumen, more reoperation. And we know that long-term people with type A dissections, even if they survive, they are dying long-term. If they leave the hospital with a patent false lumen, they have much higher risk of dying and of needing reintervention in the future. So what do we mean by extended arch repair? So essentially there's three major techniques, and I'll show you each of these that we use today. And some of these are new, some of these are not available here, but they're new technology that we're starting to use. And there's three major techniques. One is a stent graft that we put in the operating room into the descending thoracic aorta. It's a covered stent to re-expand the true lumen in the descending aorta. The second is a bare metal stent. This can go anywhere across the arch. It's uncovered. This is quite new. It's an uncovered stent, and it allows flow through the brain, and it again expands the true lumen and resolves malperfusion. I'll show you some data. And the third is a more complex technique that requires the whole arch to be reconstructed, total arch frozen elephant trunk. So I'll show a few examples of these. In this patient, we used this technique, a bare stent, but the goal for all of them is in the early days to reduce malperfusion and mortality, because mortality is associated with malperfusion, and in the later days to reduce aortic growth, remodeling, and reintervention on the aorta. We know arch operations, redo arch, thoracoabdominal, these are very, very high risk operations, so we try to avoid doing them in the future. So this is this new stent. It's called AMDS stent. It's a bare metal nitinol stent with a felt cuff at the front part of it, which you can sew into the aorta. It's very easy to deploy. This is the, let's go back. Okay, I'm going to show you this in the video here. It's an easy stent to deploy. This is one of my patients from last year. We do innominate cannulation if we can for type A dissection, if not axillary or direct aortic. It's a very easy stent to insert. It's totally uncovered. You put it into the aorta, you pull this sheath back, and then you have a felt cuff that we sew onto the edge of the aorta. This is not the patient I'm describing, but another similar patient. And then you sew this onto the aorta, and then you do a regular anastomosis in the distal ascending aorta. So it's quite straightforward to introduce. It doesn't require any fluoroscopy, wires, any special skills. It's pretty easy, and it's quite good for malperfusion. So let's move on here. Okay, so this was a study we published a year or two ago now, the early trials with this device showing that it's very good for malperfusion. When we looked at the CT scans before and after operation, 96% of the vessels that were occluded after operation were open. So it's quite a good device to resolve malperfusion. And this is a little bit more recent. We published this just a few months ago, showing good remodeling of the arch with this device. So this device is easy. There's really minimal additional risk because it's an uncovered stent. There's no spinal cord risk with this procedure. We think it's very good for malperfusion and arch remodeling. Downside, we don't know, we have no long-term data on this device. We don't know how to do endovascular intervention through this device. And if we have to take it out, it's going to be difficult. So those are the questions. In this patient, we did innominate artery cannulation. We cooled to 24 degrees. He had a large root aneurysm and a tear in the ascending aorta. For the root, we did a valve-sparing root operation, a Tyrone David reimplantation, and then we put this AMDS device at the distal end. So he did well. The videos won't play. I'm going to skip the videos for now. But basically, His scan before he left the hospital looks very good. The left carotid, which you saw was occluded, now is open, and the left femoral artery, which was occluded, is now open. So that's one technique that we have. Now, what about antegrade TEVAR? This was originated now more than 10 years ago. Initially in Mayo Clinic, and Houston did a lot of this procedure. So this one is also quite easy to do technically. Through the open arch under circulatory arrest, we put a stent graft in the descending thoracic aorta, a covered stent graft, usually a short 10 centimeter gore device, and the main purpose of this is also again for malperfusion. It will expand the true lumen in the distal aorta. If your kidney, bowel, leg vessels are occluded, this will help. So this is like a picture of someone with you can see the true lumen's very, very tiny before, and afterwards it looks much better. So this is also very easy. We think it may be good for malperfusion, but the arch is still dissected. We don't know about future reintervention, and with any covered stent in the descending aorta, we always have to worry about spinal cord ischemia, about being paraplegic if we put a covered stent in the descending thoracic aorta, and the risk is quite significant. This is another patient of mine, a recent one, 71-year-old woman. She had chest pain, left arm weakness. The CT scan showed DeBakey type 1 dissection. She had malperfusion of the left carotid, the left kidney, and the left common femoral artery. I'm going to skip the CT because we don't have it. But basically for her, we did right axillary cannulation, ascending aorta, and a stent graft. Now, she woke up with paraplegia, which is one of the risk factors, complications of this procedure with the stent graft. She woke up with paraplegia. So we put a spinal drain in immediately. We have hyperbaric therapy in our hospital. Many places don't. And she recovered completely, fortunately, her spinal cord function, and went home. And that's an X-ray picture showing the stent graft. And unfortunately, the CT is not going to play, but she had all of her vessels that were closed were open after surgery. So what about this third option, total arch frozen elephant trunk? This is the most technically complicated option, and it's the most technically demanding option for us to do, because all of the arch vessels have to be one by one reimplanted. So the operation time is longer, the circulatory arrest time is longer, the risk to the brain can be more. So there's many different options, many different types of total arch frozen elephant trunks. We use the Thoraflex device, but there's many different ones on the market. We looked at our experience in Canada with the Thoraflex. This is an early experience, 40 patients, mortality 5%, stroke 5%, and transient spinal cord ischemia of 2%. So they're not low risk procedures. They still come with quite a bit of risk. And when we looked at the literature, we reviewed all of the literature of regular elephant trunk compared to frozen, which means with the stent in the descending aorta. And we found in all of the published literature, we found a mortality benefit to frozen elephant trunk. We found that death rate was less, but 2 times higher risk of spinal cord ischemia with a frozen elephant trunk, which is to be expected compared to what a conventional elephant trunk would be. And we published some papers on when we do hybrid arches, why we do them, and what techniques we like to use in the last few months. But the benefit of this technique is that it treats the whole arch. Everything is done from the front. There's very little risk the patient will come back for another central operation, an arch operation. And it's if you have more problems in the lower aorta, it's easy to deal with. Now you have a stent there, the arch is dealt with, it's a very stable platform. But the downside is that it's technically much more difficult in an acute dissection to anastomose all of the arch vessels, and spinal cord ischemia is still a problem. So this is another case where we use this technique. This is a 59-year-old gentleman. He came in with an altered level of consciousness and abdominal pain. They first thought he had diabetic ketoacidosis, and he had no blood flow to his leg. And often type A dissection is misdiagnosed in the emergency room. It can present as a stroke. It can present as leg ischemia, abdominal ischemia, many different diagnoses. So the emergency room doctors have to be, very aware. And if anyone has chest pain and one of these other things, we always have to think about type A dissection and get a CT scan. Always have to suspect that. So when we saw him, he was seen somewhere else, transferred to our hospital. He was somnolent, but we could wake him up if we shook him, but very sick, acidotic, lactate of 13, and his right leg was very bad. This is what his CT looked like. So he had a tear in the arch, a distal tear. So he didn't have an ascending aorta tear. He had a tear past the left subclavian artery. He had in the ascending aorta only an intramural hematoma. The false lumen was thrombosed. You can see in the middle picture. He had a big pericardial effusion. He had already had contained rupture in the pericardium, and then his right leg was also malperfused. So this is a very, very sick gentleman, very high risk of death. I can't play the whole CT, but anyway. So this is what we did for him. Because his leg was already very ischemic and he couldn't move it very well, at the same time as our central operation, we did a fem-fem vascular surgeons, we called them, they did a fem-fem crossover. We did innominate artery cannulation. We cooled him to 22 degrees. We deployed this Thoraflex total arch frozen elephant trunk because the tear was so far away. It wasn't in the ascending aorta. The left subclavian artery was very difficult to get to. We just ligated it. But now, usually, this is from a few years ago. Nowadays, we would do some kind of bypass, either from the neck or from the inside, to get to revascularize the left subclavian because of the blood flow to the spinal cord. We deployed a Thoraflex graft, short 10-centimeter graft, and we resuspended the aortic valve. And this is what his aorta looks like after the operation. And he did well. He went home a couple of weeks later. He had to go to rehab. He was a little bit sick for a while, but he ultimately did well. So these are the major options for extended arch repairs in type A dissection. I would say the simplest one, the first two are actually technically quite straightforward. They can be just an ascending aorta with an open distal anastomosis and either a covered stent or this new uncovered stent graft in the distal aorta. Or if the tear is very far and it's a young patient and they may benefit from a total arch, we would do a total arch frozen elephant trunk, but which is technically much more complex, but gives you more complete repair. So right now, this is how we do, this is now in Toronto, how we think about arch pathology in the setting of acute type A dissection. So if the patient has a DeBakey type 2, so meaning only in the ascending aorta dissection, or it's an older patient or with an uncomplicated dissection, then in these patients, we still do a standard ascending aorta hemiarch resuspension of the aortic valve. If it's a DeBakey 1, meaning the whole aorta is dissected down to the distal aorta, and they have some high-risk features, and the high-risk features that we say are an aneurysmal arch, a distal tear, malperfusion, a descending aneurysm, maybe if they're young, but not always, then we would do an extended arch repair. And in these, we have three options: the TVAR, the uncovered stent, and the total arch elephant trunk. The first two, I think, are quite good in people who have malperfusion. It's easy to do, and it's an easy fix, and it's very good for malperfusion. The third option is really reserved for patients with arch pathology, the tear which is far away, an arch that's aneurysmal, and if it's a surgeon who's comfortable doing a total arch in the setting of dissection. So we really, though, right now don't know exactly who will benefit from extended arch repair. Right now, all of our decisions are based on very small retrospective series from case reports, small series from small centers or IRAD, GERADA, these registries that we participate in. What we really need is a randomized trial of dissection to know exactly who would benefit from these techniques. So this is a trial that we're just starting in Toronto and across Canada, and it'll go to the US as well. So I initiated this trial, and it will take patients with DeBakey type 1 dissection and randomize them either to regular hemiarch or an extended arch, one of those three techniques that I described. Any of the techniques, because you can't tell surgeons exactly what to do. Surgeons, they want to do what they want to do. So we offer you can do any of those extended arch techniques for this trial. And this is important because it will help answer the question exactly who would benefit from from these more extended operations. So really there's a variety of approaches to extended arch repair in acute type A dissection. The technique really depends on the patient's presentation and the anatomy. We look very, very closely at the CT scan. We look at it, 100 times before the operation to see exactly what is happening and what we think would help the patient. And also, of course, the local available tools and resources. The bare metal stent, very few places in the world have it right now. In Germany, in Canada, and that's about it. The US doesn't have it. So not every place will have each of these techniques. And of course, there's logistical challenges. Is there a dedicated aortic team? The device cost and availability is a very important concern. These are all expensive devices. But several of the techniques, you don't need a lot of extra equipment or skills. Two of the three techniques are quite straightforward to implement and easy to use. In our center, we have an aortic team, 4 of us who only do the aortic operations. And so if there's a dissection or any aortic problem, it'll come to one of the surgeons who specialize in aortic problems. Our field has become much, much more subspecialized as time goes on. And so I don't do transplant, VAD, heart failure, that kind of thing, but they don't do aortic work either. So it's become a little bit more niche in our group. So to summarize, type A dissection remains very challenging. Standard hemiarch repair is really inadequate for patients with arch pathology, and several approaches have been developed to extended arch repair, and they depend on clinical and logistical issues. And we really need randomized data to understand exactly who would benefit from these techniques. And hopefully this trial that we started is just getting started, but hopefully in a few years we'll be able to have more solid data to understand who would benefit. So that's my talk. I wanted to show a few pictures from just a few pictures for you guys. This is Dr. Caselli. This is the gentleman who I trained with in Houston. I spent 1 year with him after my regular cardiac surgery training in Canada. And he is an aortic surgery expert. He's done thousands and thousands of aortic operations. He operates 7 days a week, everyday surgeries, all only complex operations, arches, valve-sparing roots, thoracoabdominals. It was a very excellent year. These are my teachers in Toronto. This is me at 36 weeks pregnant, about to start a thoracoabdominal operation with Dr. Feindel, who's one of my mentors there. And this is Tyrone David, who is my partner in Toronto. This is him helping me with my very first case in Toronto now 8-9 years ago. It was a 26-year-old with a ruptured thoracoabdominal aneurysm, 11-centimeter aneurysm. So he helped me with my first operation there. And now these are my students now who are now learning to become aortic surgeons in Toronto. This one with the camera is Jennifer Chung. She was our aortic surgery fellow, and then once she finished training, we brought her on as staff. Now she's faculty in our program, and these other two are also, one's a vascular surgeon, one's a cardiac surgeon who recently were aortic surgeons. We have a lot of women doing aortic surgery and more women in our field. Somehow our last 4 years, all of our fellows have been women. So I don't know why, but that's how it is. And this is our aortic surgery clinic this year. Everyone's wearing a mask, but we have a multidisciplinary clinic: genetics, cardiology, vascular surgery, cardiac surgery. We do a clinic to look after aortic patients all together. And this is my family. We do try to have a life outside the operating room. I have 2 little boys, very supportive husband who's not a doctor, he's normal, and very, very supportive. He helps with my mom and his mom to take care of these little guys. And this is my dad. My dad is the reason I'm here visiting Armenia right now. He's a dentist, an endodontist, and he has been doing work in Armenia for 30 years. He started clinics in Artsakh, Vets dental clinics, free dental clinics. So he's been doing he's been doing work here for a long, long time. So he lives here now. So he loves Hayastan and Artsakh, as do I. Thank you very much. Thank you. Questions? I'd be happy to answer questions. Հայերենով, անգլերենով, հաջիկ հարց։
Շնորհակալ ենք շատ, դոկտոր ջան, եթե դուք ունեք հարցեր բժշկուն, կարող եք ձեր հարցերին պատասխանի։
Շնորհակալ եմ ձեր պրեզենտացիայի համար. Thank you very much for interesting presentation, and I have a question. Do you always organize post-operation CT or no?
Post-operation CT always.
Always.
Yeah. If the kidney function is normal, kidneys,
Երիկամները.
is normal, then before they go home, they get a CT as a baseline, and then 6 months, and then every year.
Yeah, okay.
If there's no problem, after a few years, we can stretch it out every few years. But we have many patients who had type A dissection, had a good operation, and then no one did a CT scan for 20 years. And then they come with a 10-centimeter aorta because no one has looked at it. Even if they have a cardiologist, sometimes they do echo, but they don't look at the rest of the aorta. So very important to do CT or MRI. At least periodically. We like to do it before they go home if the kidneys are okay, and then 6 months, 1 year, and then every year.
Thank you very much. We are listening to you with pleasure. Thanks.
I have a question. Thank you very much for your interesting presentation. Dr. Karine did not present it her. She's an adult cardiologist. I'm Christine. I'm adult cardiologist in our clinic. And I also interested in aortic dissections as a pre-operative care. And in our center, we perform a study, a pre-operative risk adjustment. And I was also interested, how did you, whether it was challenging to receive the ethics for your study, for randomized control study, and whether it is possible to include our center in that study, if our doctors don't mind.
Most of our studies are retrospective in cardiac surgery. Very few prospective randomized studies. In cardiology, there's thousands, thousands and thousands of people have been randomized. This stent or that stent, ticagrelor or Plavix, whatever. So much more data from cardiology than from cardiac surgery. So it's very important that we acquire randomized data. This study is not an easy study. Ethics gave us a hard time, but the argument is scientifically we do not know. We have no idea, and in the community there is equipoise, meaning we don't know if this is the right answer or if the other is the right answer. So ultimately, after many months of discussion, they have agreed, and right now it's only in Canada, the trial, but of course, we're happy to expand it, but it's we have to have some of the devices are very expensive and not available everywhere. Yeah.
We have doctors that are watching us from Artsakh, yeah. And if you have questions, please ask Dr. Ozunyan. Եթե ունեք հարցեր, կարող եք հիմա մեզ արցանց միացել են իրենք, այո։ Ունեք հարցեր։ Ողջունում ենք ձեզ։ Դուք ունեք հարցեր դոկտոր Ուզունյանին։ Արցախից։
Բարև, ողջունում ենք Արցախի հանրապետական հիվանդանոցից։
Ռոնից։ Ողջունեք հարցեր, շատ լավ։ Իսկ մեր բժիշկները։
Thank you. Thank you for sharing with your experience. I have a quick question. Do you need some special anticoagulation when you use bare metal stent?
Good question. Right now, we only do aspirin. Aspirin for these patients, no anticoagulation. But we have had some thromboembolic complications with the Thoraflex. Actually, we're studying it right now because we have seen clot inside the stent graft, and we don't know, maybe these patients should be anticoagulated. So we're gathering data from 10 sites in Canada who do these procedures to see what the rate of thromboembolic complications are. So right now we only anticoagulate if we see clot somewhere on the CT scan, but otherwise only aspirin.
Okay, thank you.
Ավետի Սահարոնյան from Best Life Medical Center, yeah?
What about really challenging cases when you are don't know how to cannulate, especially arterial line cannulation or bypass? Have you ever been in a desperate situation in terms of cannulation? Thank you.
Yeah, thank you for the question. Very important question. So our cannulation strategy has changed over the years. Now, we look closely at the CT scan to see the options. Preferred cannulation for me is innominate. If there's no dissection, open the chest. Before we open the pericardium, we isolate the innominate artery, put a side biting clamp, and sew a 8mm graft. Pretty easy and good blood flow to the brain. If the patient's stable, many people do right axillary, as you know. But more and more now, we have been doing direct Seldinger needle wire cannulation in the ascending aorta. For this, you need a transesophageal echo to make sure the wire is in the true lumen. But even in cases where a lot of malperfusion, there's no place to put a cannula, Seldinger in the ascending aorta is pretty good, and it works quite well under echo guidance. If we're doing CPR on the patient, we do femoral cannulation. There are patients where there's really, you have to do something unusual, left axillary cut down or left carotid cut down, sew a graft onto it. Transapical, I've never done, but it's a possibility. But usually now we prefer, the fastest way is really needle wire and a regular cannula in the ascending aorta with transesophageal echo. Before I did it, I thought, this is crazy. It's ruptured, it's purple, it's not going to be nice, but in fact it's pretty straightforward and it works quite well. We always have wires at least in the groin, femoral arterial line and venous line, in case it really ruptures, and then we compress, give heparin, and then do femoral cannulation to go on bypass. Yeah, but it is still a challenge. Yeah.
Եթե չունենք հարցեր, մեկ անգամ եւս շնորհակալություն հայտնենք բժիշկ Զունյանին։ Մենք միշտ ձեզ սպասում ենք Երևանում, Նորմարաշ բժշկական կենտրոնում։ Համեցեք։ Մենք էլ ենք շնորհակալ։ We are happy to see you always. Հիմա պետք է արդեն բժիշկները գնան դեպի վիրահատարան, որպեսզի Այնտեղ աշխատեն, այո։ Շնորհակալ ենք բոլորից, նայեք մեզ ուղիղ եթերներում, հետևեք մեր էջին։ Ստեսություն։